weird how they presented the chapter, because they go with the manifestations first and the complications before the cirrhosis. So let's do our best to make sense out of it. Let me start with story. So let's say this is Chanel. This is Chanel's heart. Lungs. Let's skip the lungs. Start with the esophagus. So esophagus, stomach, right? Then the liver is here, correct? And this is the portal vein. And then this is now the inferior vena cava. Oh, let's just put it here, inferior vena cava. And the lungs, right? So you can say that these are the small bowels. Okay, pancreas over here, spleen in the back. Okay, so so the liver is basically like the last organ before the blood has to pass through, right? Before it enters the heart, correct? Okay, so is it a major thoroughway for blood? Yes. Okay, so the portal vein is a huge vein, right? Portal vein, and then since all that blood passes through liver tissue, so what will happen to all that blood after it when it passes through the liver? What will liver do to all that blood? Right, so it will metabolize whatever is in there. So you've got toxins, drugs, and then protein passes through there. Okay, so liver will take care of it. Okay, so clean it pretty much, and then it goes into the heart. Okay, and then goes to the lungs, and you know the story. So everything from the GI, and then all things below will pass through the portal vein. You hear? Okay. So therefore, if when you have cirrhosis, and we'll talk about the 3 causes of cirrhosis shortly. So cirrhosis is basically when you cook your liver. You've seen liver tissue in the grocery. Who has not seen liver tissue? Okay, so everybody knows what liver looks like. Have you ever touched it? Red, squishy, right? Dark red. What makes it that color? Why is it dark red? Yeah. So that means what's the very vascular? Okay, so any organ like steak, for instance, anything that looks red is red because it's very vascular. There's so much blood in it. Okay, so many blood vessels, billions of capillaries are in there. That's what it gives it that red color. So when you put that liver, that red, squishy, soft liver on the grill for 2 minutes on each side, is it still soft and squishy? It contracts, right? Yeah, it shrinks and it's now edible. Yeah. So that's what basically is happening to your liver in cirrhosis. So there are 3 causes Shrinks. Shrink, right? Yeah. So one is alcohol. If it's alcohol, we call it Lennox. Lennox cirrhosis or alcohol cirrhosis. Lennox, just a name, but it's basically alcohol in those cirrhosis. And then second is hepatitis, yeah, B or C or even A and E, viral. Then three is biliary obstruction. You know, when you get gallstones, and then that causes a blockage, and yeah, that can cause liver cirrhosis. Yeah, it starts there, and then if you don't treat it, of course, the liver will suffer. Okay, so let's study what will happen if the liver is cooked, or you have a cirrhotic liver. So it's now very shrunken. So what happens to the blood vessels inside it? Okay, so they're smaller, narrower now, correct? So can it still do its job? No. So what will happen to, there are four functions, major functions. There are, of course, others, but there are four major functions of the liver. One is metabolism. Okay, so yeah, so metabolism, and then as Abigail mentioned, protein synthesis. Okay. Yeah, CHON is protein. And then next is it's because it metabolizes vitamin K, so therefore we need it to make clotting factors. So with vitamin K, it's able to make clotting factors. Okay. Then it also okay, so with yeah, storage of glycogen. Okay. Right. So what will be the effects if your liver no longer works normally? Well, no, glycogen storage is, remember, glycogen is simply your emergency glucose store. Let's not worry about that too much. We'll worry about the major effects. Okay. So with protein synthesis, what will happen therefore to your overall albumin levels? Okay, decrease albumin. And what is the purpose of albumin in the body?
Transport protein.
It is protein. So what will it do? Let's talk about plasma, since plasma is mostly water, and then okay. Oh, I forgot one thing. Let's just replace, since glycogen is not really that necessary here. Yeah, so it's going to have ammonia elimination, correct? Ammonia is a nitrogenous waste, waste from protein metabolism. Okay. So what happens to your albumin levels again? Okay, so therefore, since albumin is a major component of plasma, meaning it's what's responsible for holding water in blood in plasma. So what will happen to fluid volume in the blood? So what will happen to you now? Edema, actually. Because remember, yeah, because albumin holds water in plasma. Without albumin, can plasma hold water? No. So where will all that water go? Outside. So it will cause edema. So of course, edema will form where? In the extremities. Okay. So your patient will have lower extremity edema. But blood pressure will therefore Well, this part is weird, okay? So volume-wise, intravascular volume will be what? High or low? Low, okay? So blood pressure will tend to drop, okay? So, however, because of the traffic here, because remember all the blood, right? From the esophagus all the way down to your toes, all that blood has to return to the heart via the portal vein, via the major vein in the liver. So can they pass through there? No. So is there congestion now? All right, congestion where? Everywhere. Okay, from your legs. Will there be congestion here in the esophagus as well? So yeah, so therefore, what will happen to all the veins? What will you form? Well, there's traffic. They cannot pass through here. So imagine all the traffic here. So go through the Midtown Tunnel. The Midtown Tunnel is the liver. It cannot it can't allow all the traffic through. Okay, so let's say there's only one lane instead of two. Okay, so what happened? So what will happen to all the veins involved here? They will all get distended.
Oh, that's what called the encephalopathy.
Well, no. We'll get to that later. So what will happen is there will be varicosities, yeah? So you'll have leg varicosities, and you also have hemorrhoids. Yeah, that's possible. But will there be varicosities here in the esophagus as well? Yes, the problem with these esophageal varices, when we say varices, yeah, they basically varicose veins. They're inside the esophagus. So if this is my esophagus, that's where food enters, correct? The varicosities are not outside, they're inside. So when I eat tacos, chicharrones, what will happen? No hot sauce. What will happen? You have veins there and you're exposing it to all those spicy stuff and everything. And what could happen? They could bleed. Okay, so you expose, right? These patients, so every cirrhotic patient, every patient that has a diagnosis of cirrhosis, what's your number one priority? It's bleeding. Watch them for bleeding. All of them, you assume, oh, this patient has varicosities. Okay, so you watch them for GI bleed. Very high risk for GI bleed. Oh, you can't stop the patient, but
No limit.
yeah, you have no control. Free country, remember? Free country. Huh? Yeah, of course you can teach the patient, okay, to avoid any irritating foods. Okay, so they're high risk for bleeding. And where's the bleeding coming from? These varicosities, okay, these esophageal varices. We'll get to management later. Next is, now since we have traffic here, so will all this congestion do what? So we go back to heart failure. So in heart failure, there was congestion too, correct?
Yes.
So in left side heart failure, what happened? What were the patient's manifestations? Or even right side? All right, so there was distension, but this is not the heart though. This is the liver. Correct. So why did we have crackles in left side heart failure? Because the pulmonary veins started leaking, correct? Pulmonary veins, remember, carry oxygenated blood, yeah? So since there was traffic in the left side, left ventricle, so what will happen? It will leak, right? Right. So when the veins pressure reaches a certain point, it will start leaking water. Same exact thing will happen here. So when these vessels here leak, these veins leak water, where will that water end up? Okay, so edema not only in the peripheral extremities, but also, right, we call that ascites.
I've seen that in
Okay, so yeah, so if you put Any patient from Pakistan, from the Philippines, from China, from Russia, from the US, from Europe, from South America, you put them all in one ward and they all have cirrhosis, they all look alike.
So the yellow.
They all look alike.
Yellow and swollen, like their bodies are like general.
They will have the same, like, all like, oh, are you all brothers and sisters? Yes. Okay, they have the same profile. Really large. Hey, don't laugh. These people are dying. They all have really big legs, really big bellies, skinny arms, all yellow. Okay. Of course, they have different skin color to begin with, right? But when you look at their eyes, their palms, similar. Okay, similar, yellow. Because of course we'll see yellow in you and me, yeah. But other people's color, let's say those really dark Africans, for instance, it will it will also turn yellow, right? And then the eyes, okay, we have all the same color sclera, so they will all look the same. Okay, and also on the mucous membrane, start turning pale and have a yellow tinge. All right, so we talked about bleeding. So what will happen to their bleeding times? PT, INR, PTT, all increase. Because remember, this is related to low clotting factors. So increase risk for bleeding, increase INR, PT, PTT will all be elevated. They're also at risk for portal hypertension. So the portal hypertension, we understood the concept. Portal hypertension is brought about the congestion here, correct? So the portal hypertension will lead to the esophageal varices. And of course, contribute to the ascites and the edema. Right, so we have the portal hypertension that leads to that. And okay, so you have an idea already, yeah? Okay, so and then finally, Miss Jennifer talked about encephalopathy. So this is now damage to the brain brought about the ammonia. So the ammonia levels rise, patient will have mental status changes, cognitive decline, confusion. So they'll become violent, no longer recognizing people. And this is acute, okay? This is not really like it develops over time. This is acute, like they're fine yesterday, have mental status change today. Okay, so groggy, lethargic, or if they're not lethargic, they're awake, they are very violent. Okay, so encephalopathy can go either extremes. Okay, so like bedbound, obtunded, no longer responsive, to like aggressive. Okay, it just depends. So that's how we tackle the chapter now. So where do you want to start? Okay, let's start with jaundice. So of course, this is the yellowing of the skin because of abnormal levels of bilirubin. So when you have liver disease, you cannot get rid of bilirubin anymore. So that reflects as jaundice. So your urine will turn dark, skin and eyes turn yellow. There are different types of jaundice, but they all reflect the same manifestations. Yes.
So what about the color?
Yeah, so the stool will also no longer look brown, like normal. So they'll turn pale. That reminded me, I had a nephew who had really pale stool. He was still a little kid, so sometimes he doesn't wear a diaper. He runs around the house and then drops feces, right? And I thought, what's wrong with this kid? He was an older child already. And I said, Oh, let's get him checked for, but he doesn't have the symptoms of liver disease. What's wrong with this kid? Then I discovered that all he had was milk. Like he wouldn't eat. We're not that, him and then my brother weren't really that close. And because of, an in-law issue. So I didn't know the kid that much. So when he visited the house, and I don't remember the exact details why he wasn't in diapers. Oh no, he was an older kid. He wasn't supposed to be on diapers anymore. So he was, so feces dropped on the floor. So what the hell is that? So he was drinking. So yeah, so that's just a weird reminder. Okay, portal hypertension. This can be managed with propranolol because it's hypertension basically, right? So we can give vasodilators, so beta blockers, but the preferred one is propranolol. So this will help return, with blood return, so decrease um, blood pressure in the liver circulation, then increases venous return, improves cardiac output. And this will again help with the ascites, right? And also with the varicosities in the esophagus, and then congestion also in the spleen and the pancreas. Yeah, because remember the patient has low intravascular volume, correct? So you still monitor blood pressure before you give it because it can lower blood pressure. And then ascites, so we'll talk about the what's in this thing. So this will basically serous fluid, right? So this is water from the bloodstream escaping and then gets trapped within the peritoneum. Now the peritoneum technically is sterile, correct?
Yes.
The GI tract is not, it's dirty, but then the peritoneum is sterile. However, can there be contamination of this ascitic fluid? Yes, this fluid can grow bacteria. So when we drain this, we always send it for pathology. Okay, because we want to see, is this containing any infectious organisms? This can cause peritonitis and cause sepsis. So the patient's abdominal girth will increase because of the accumulation of up to 4 to 6 liters of fluid here in the abdomen. So they look really pregnant. Okay, and then that's enough, of course, when you have some of you are moms here. So what can happen if, let's say, your abdomen gets really that big in such a short time? Because at least with pregnancy, yeah, you still get stretch marks, but that's over 9 months, right? This one will grow in a few months. Okay, this is not gonna grow in 9 months. So this can grow big in a matter of 6 weeks. Okay, so in 6 weeks you look like you're 9 months pregnant, but it happened in 6 weeks. So what will happen to the skin? Really stretched. Okay, so you'll have spider veins as a result. Remember, there's congestion also. So it look really, the abdomen will look fragile. And then once the abdomen's that big in such a short period of time, so what happens to the breathing now? Okay, so diaphragm can't contract down. You have really large and high intra-abdominal pressure. So what will happen? Shortness of breath now. So usually when patients have these ascites, they're fine until one day they can't breathe anymore. Then they'll go to the hospital. They're suffocating, literally. So they'll go and then we'll tap them. They can also have hernias. Okay, they can develop hernias as a result. Management. So let's start with, so the goal is to reduce that fluid, correct? So we'll try to reduce the accumulation, but if they have acute symptoms, we have to drain that quickly. So first, nutrition. So this will help decrease the accumulation. Of course, what's the nutrition? You have fluid from, okay, so decrease, oh, not protein yet. We'll talk about the protein modification later. Fluids, okay, so fluid restriction. And then what's the diet? Low sodium. Okay, so 2 grams sodium, so low sodium diet. So remember your heart failure education. Okay, so here are, because of course, nobody wants to be on a low sodium diet, right? Do you? Nobody does. So here are substitutes. Okay, lemon juice, oregano. Okay, right. So be careful again with cheap, especially cheap salt substitute. There are salt substitutes that don't have potassium. So here's the warning: most salt substitute contain potassium. Okay. And remember, these patients may have heart disease as well. Because who are these patients again that get cirrhosis? Alcoholics, right here. So we have here Lennox cirrhosis, and let's say how did they get hepatitis? So are they really? Oh, except of course, you know, we travel, but mostly are these IV drug users also? Okay, so same people, yeah. So not exactly the right. So they have other problems as well. True too. Right, so these are your dietary. So now let's go to pharmacologic. So diuretics and fluid with sodium restriction. The doctor, of course, decides which one, if it's spironolactone, the potassium sparing, or thiazide or loop diuretics. We have no, that's not our job. Then we have daily weights, okay? And then all the complications that come depending on which diuretic was used. Okay. Now, when the liver is infected, doesn't matter if it's cirrhosis, or if the liver is diseased, whether if it's cirrhosis or hepatitis, for instance, the patient will always be placed on bed rest. It's a lot. It's very tasking to have this. Plus, rest allows the liver to recover. Okay. So rest is important. Okay, this is now the invasive procedure. This can be done anywhere in the ER or at the bedside, ICU, doesn't matter. We can do paracentesis in any setting. Most doctors, though, especially in magnet hospitals, do this in the radiology department because they want to do it safer under fluoroscopy guidance or under ultrasound guidance. That way they also avoid complications such as nicking the bladder because you insert a needle. Plus, is the water really in one spot? Because you have your stomach there, small bowels, your kidneys are there, your large bowels are there. So are they in one spot? They're scattered all over. So one of the purposes of ultrasound guidance, besides making more money, as your friend here is implying, is really to find the largest pocket of fluids. Okay, that way we maximize the drainage. Yeah. In the Philippines, because my brother does this a lot, he always goes through the umbilicus. Of course, this is the third world country. Okay, so he figured I'll just go through the belly button because it's right through in the center, and then he always gets good drainage out of that because there's no ultrasound or fluoroscopy involved. Okay, of course, this is that doesn't apply here. So our duties for patients, look at this. You can have up to 5 to 6 liters of fluid removed. That's a lot of fluid removal. So is this going to cause complications?
Yeah.
All right. So what are name a few complications? This hypotension is number one.
What is the heart, the thing like with the heart rate?
Yeah, basically loss of large volumes in a short period of time because this is going to drain in less than an hour. Imagine removing 5 to 6 liters in less than an hour. Right? You have a question?
No, I didn't hear what you said. I told him that.
No, there'll be a blood pressure drop here
Uh-huh.
because of the large volume removal in such a short period of time. Right. So our duty here, because there's always the danger, because the most, where do you put the needle to drain this because the patient is in a sitting or standing position. Most of them are sitting like this. So where will you put the needle to drain fluid? Here or down here? Of course, down here, correct? Yeah, because fluid will go down by gravity. So what will happen if you nick it here? Bladder injury. So you could potentially, because the fluid, when you nick the bladder or the peritoneum, same fluid will come out, right? It will look yellow. All this fluid here will look yellow, so there's no difference whether, you thought you're draining peritoneal fluid, but then you're actually draining urine, right? Right. So that's another purpose. So to lessen that possibility, what is your responsibility before sending the patient down to the procedure? Well, now, okay, tell the patient to void. Okay, they must void before the procedure. Yes. Oh, yeah, of course. You nick the bladder, so you puncture the bladder. That's another problem. So your responsibilities besides weight, right? Because we need to know how much fluid. Okay, so you weigh the patient before and then compare it after the procedure. Then most important is the voiding, emptying the bladder, okay, before the procedure. And what else do you think? Vital signs, yeah. Okay, we want vital signs before and after the procedure. Okay, medications, because this is invasive. What would be, this is your initiative, okay? You're thinking about the patient. They use local anesthetic. So no sedation. Yeah, patient's wide awake here. So yeah, they'll do a local anesthetic. But just thinking overall complications, because this is invasive. And these patients, remember, are on bed rest, correct? So what is automatically ordered as part of prevention? They are usually on anticoagulants, yeah? So to prevent DVTs, because they're on bed rest. So what will you do? You initiate it. So what will you do with that day's anticoagulant? Okay, so ask for an order to hold it. Okay, so some doctors may not, well, good doctors will of course write in the order, right? Next to the NPO. So okay, NPO, then they'll say, okay, hold these drugs and everything. But sometimes they don't. So it's your responsibility to watch out for your patient. All right, are we clear? Yeah, ask the doctor because you can't hold it. I mean, you're a nurse, so you have to get an order, at least for that day.
Given
the propranolol?
As depending on what was your patient's blood pressure before the procedure. If it's high, yeah, you give the propranolol. Not, of course, you hold it.
But let's say it's high.
Oh, that's fine because you're still covered. It was high because technically, yes, this fluid is not in the intravascular compartment. I mean, it's not. Yeah, it's not. Right, but because of the rapid shift, because changes in osmolarity, remember, so it will still affect the blood pressure. Okay? Fluids will still shift as a result of the rapid fluid removal. Even though this is not in the cell, this is not in the bloodstream either, right? This is fluid in between. So it's in the interstitial, if you think about it. That's some interstitial there. All right, let's talk about tips. Now, some patients, of course, after we drain acidic fluid, is it gonna be a one-time thing? Okay, yeah, all right, I feel better, I can breathe better. Patient goes home, right? Starts drinking again. Oh, I'm good, right? So is this a cure for the liver cirrhosis? No, it only managed the ascites. Now, when this ascites comes back again and again and again, especially if the patient did not comply with the teaching, meaning they were told, okay, do sodium restriction, stop drinking alcohol, stop these drugs you're taking, right? Because it's not just alcohol, it's drugs too, right? They take hepatotoxic medications or prescribed or illicit otherwise, damages the liver. So it goes again and again and again. So let's say the patient is now debilitated. Yeah. So can they afford to, they're gonna die anyway? And you want them to go for paracentesis every 2 days? No. Since they're going to die anyway, this is an option. TIPS. TIPS is transjugular intrahepatic portosystemic shunt. Okay, let me show you the picture. this is not a first line. Let me emphasize. This is not something, oh, you see ascites, oh, let's do tips. No, this is not, that's not a routine. Okay, so tips is only reserved for what again? Yeah, so advanced cirrhosis. Okay, those who, right, so those who receive or required paracentesis, let's say 3 times last week or every week for that matter. Every week they're here. We tap them. Next week, see them again, tap them. This is going on for a long time. Huh? No. Okay, so look at the shunt. So they put a shunt through, they're basically bypassing the liver tissue. Look at the shunt. So they put it in the inferior vena cava, right? And then through see where they bypass the liver altogether? Because this is the diseased liver. It's no longer basically because that's why the patient has ascites repeatedly, is because the veins, the portal circulation is very very narrow now. Okay. However, one thing about the liver is even though it's diseased, it will still work. Meaning not the whole liver, but of course there are places that are alive, right? Yeah, so there are pockets there that are still functional. Okay, so those liver cells will do their job because they're alive. However, if you bypass it altogether, that means is blood going through any liver tissue? No. Not at all. So you're basically saying, yeah, this will relieve all the congestion, no problem. So no more esophageal varices, they will go down. Okay, all the the edema here will resolve, right? No more ascites because circulation is good. Okay, blood goes out, goes down, goes back up. There's no more traffic because you bypassed it. So you're no longer passing through the diseased veins, right? You're passing through this really large shunt. So blood flow is good, yeah. But again, liver tissue, if they're alive, they will continue to do their job, including cleaning. Okay, cleaning the blood of ammonia. So they'll still do all of these job here, even though they're diseased, but only those small pockets that are alive. But if you bypass it altogether, are these still possible? No more, because you bypass the liver. So what will happen to your ammonia levels after this procedure? You will get worse. Okay, so that's why, is this the first line? Last resort. And then therefore, what would you expect to have as a treatment after this procedure? Okay, we'll get to lactulose later because that's the only way we along with dietary restriction. So you understand how this thing works? All right, so is this again first line?
No.
It said last resort option. Yeah, so this would be like part of palliative management. Here, because of development of ascites in patients with cirrhosis associated with 50% mortality rate, so we consider TIPS. Yeah, because of the ascites. If you get repeated ascites, because there's a big chance you could get peritonitis here, and then you go septic, it's easy now to die. So these are your nursing job: intake and output, measuring the abdominal girth, patient has ascites, daily weight. Okay, let's proceed with varices. So this is another cause of death for the patient. They'll bleed to death, upper GI bleed. So I described what it looks like. So what causes these veins, varicose veins, to form in the esophagus? The portal hypertension. Okay. Here's teaching for the ascites patient, which we already discussed. They just summarized it. Okay, remember it includes alcohol cessation.
Okay, that's
Yeah, this is the only because all other conditions, did we ever tell patients to stop alcohol? Right, moderate, right? Even heart disease. Heart disease never said stop alcohol. We said stop smoking, but we never said stop drinking, right? This is the only exception. Okay, in liver disease, no alcohol is beneficial at all with liver disease. So again, with repeated ascites, okay, watch for peritonitis. It can lead easily to sepsis. So let's continue with, what was this again? Varices, okay. So bleeding, esophageal varices, I won't repeat the actual acute bleeding management because it's no different from the GI bleed we had in peptic ulcer disease. So management is the same, which is fluids, blood products, okay, and then repeat. And then did we give also PPI in GI bleed? Oh, same management, okay, so same.
Just the zones.
The what? Yeah, PPI, yeah. Or H2 receptor blockers as well. So here are your management. So since these factors contribute to bleeding, which is lifting heavy objects, straining at stool, sneezing, coughing, vomiting, so this will precipitate bleeding of these varices. So what would you tell the patient not to do? Okay, these, right? So we limit the heavy objects like to maybe 5 pounds. Is sex included here? Yes, because when you have sex, you're basically straining too, correct? So that would be included. So then what? Okay. Okay, so you got here. Of course, again, I won't repeat because signs and symptoms of acute bleeding. Okay, so remember hypovolemic shock. To diagnose, we have to see it, right? So what would be a test to see the varicosities? Remember, it's inside.
Yeah.
Okay, endoscopy. So patient will have EGD, then we'll see. While they're there, it's not only diagnostic, they can also clip them. Okay, so if they see, oh, this thing's pulse, really big, so they'll put a band around it to prevent it from rupturing. Okay, they're that big enough.
That's what they do with them.
Yeah, so that's banding, or they clip them, for instance. So no different from, let's say, from aneurysm repair. So what are your duties? A patient has to go for endoscopy. NPO. Okay. All right, that's it. Because it's, again, like I said, same as bleeding. Now, to control bleeding, expect octreotide to be given. Octreotide or vasopressin. This is an IV. So this comes, you'll have to prepare it yourself, or sometimes pharmacy prepares it for you. Octreotide comes in a tiny little 1 ml vial. It's refrigerated. So you just mix it in, I think, 250 of dextrose or saline. And that's it. So it's a continuous infusion. All right. So it has to be a dedicated line. You can't mix this with other antibiotics because these patients, remember, are on antibiotics too, right? Ascites, so they're on prophylactic. We usually use flagyl, okay, or metronidazole for these patients because we know high risk for peritonitis. So they're on antibiotics, and then high risk for bleeding, octreotide. So octreotide, the brand name is Sandostatin, coming from the hormone somatostatin, okay, because that's what octreotide is. So the brand name is Sandostatin. But so don't be confused. This is not a statin drug, all right? You might confuse it. Oh, you hear Sandostatin. No, that's octreotide. So this will decrease bleeding of the, because it's vasoconstrictor, basically.
But would that increase the pressure on
It can be a, but we don't really see that a lot.
specific?
No, this is not like Levophed, like norepinephrine. No,
No, not that.
no, this one.
There's more pressure. like for that specifically.
No, not this one. I mentioned beta blockers. Okay, propranolol again is preferred. Okay, so for acute bleeding, so just like we had tips, right, for last resort. So this one is management for acute bleeding of esophageal varices. It's not a pretty picture when they do this thing. So the patient is sedated because no, the balloon is big. Okay, so it's going to be inserted through your mouth or through your nose, most cases through the mouth because it's a big catheter. So if we put it through the nose, so traumatic, so we put it through the mouth. So therefore, high risk for aspiration, yeah? Now, it's no picture here, but let me show you. The balloon is called a Sungstaken-Blakemore tube. And that's the tube. So it's big. Look at the size of that. Through your nose or more often through the mouth, runs through here. There are two balloons here, one here and one here. So since most esophageal varices are found in this area here, so from the antrum of the stomach to this part, the lower part of the esophagus, that's usually where the varicosities form. And they can also go here. So that's why when you inflate these balloons, this will of course compress the blood vessels, okay? Compress them and stop the bleeding. Number one concern, of course, again, is aspiration. It's a huge balloon. Okay? It looks nice on the picture, but on remember, these patients are bleeding, and then so it's messy, right? So when you insert this, and then of course there's blood. Okay, so this patient is not clean like this. Okay, so this patient has already been vomiting blood, okay, before they got to the ER. So they're messy. Then you insert this, so everybody is bloody. All right. So you put it in, insert it, get X-ray, confirm placement, proper placement of the balloon, and then clean up afterwards. All right. So it's nice looking at this, but in reality, these are bleeding patients. Okay, vomiting blood, aspirating blood. We put this under, in the most stressful conditions.
So
Yeah.
that's a question. This specifically is to help control bleeding.
Acute bleeding, meaning we can't, it's actively bleeding. You can't do endoscopy. It's actively bleeding. We have to stop the bleeding first. Then we'll do endoscopy later, right? We have to stop because this patient would bleed to death, literally. So you stop this bleeding, this will be in for 1 to 2 days. Once bleeding stopped, the hemoglobin is stabilized because we're transfusing too, right? And then once everything's good, then we'll take care of those varicosities. So endoscopy will follow, but we can't do endoscopy, right? The patient's still bleeding. You have to stop it first. Okay, so your number one concern, if the patient has, yes, is aspiration. So of course the patient has to be NPO here.
So who do you call?
That's not our concern. We're not feeding this patient. All right. Yeah, they'd be fine. You won't die 1, 2, or 3 days without food. Right. So here's your responsibilities. Patient with a balloon tamponade must remain under close observation in the ICU. Very effective, but just again, expect a messy, a big mess. All right. Sclerotherapy. So this is now the following day or 2 days later after balloon tamponade. So they'll do these endoscopic procedures. So we had ligation of the varicosities or sclerotherapy. If they're small, we can do sclerotherapy. We destroy just like how they take care of leg varicosities. And cosmetic surgeries, they do sclerotherapy, they can do the same thing. And we already discussed under peptic ulcer disease, GI bleeding, same, right? So peptic ulcer, bleeding, antacids, H2 receptor blockers, PPI. And there's really none here. I won't test these. I mean, we have no role here. This is in endoscopy. And we already talked about tips. Okay, let me just look at the detail here. So after tips, no, it's not here. Let's go to encephalopathy management. These others, again, I'll go through, I'll skip them because we have no roles in the other procedures. We are involved in the balloon tamponade, okay, because you're there and you're transfusing, giving the drugs, and you're taking care of the patient while they have the tube. The others are all in the OR. Right?
I have a question.
Mhm.
So you just said the others are on the OR, but there's an OR nursing OR, so why?
You're not expected on the NCLEX, if you look at the blueprint, nothing there says intra-op. It's always pre and post-op care.
Oh, so that's the thing.
Yeah, there's no question intra-op. So, okay, encephalopathy and coma, because the complication, if you don't treat encephalopathy, is the patient goes into coma,
Mhm.
and not all of them recover, right? So Escarda, the last name Escarda is associated with alcohol. So if you go to my hometown, Escarda, because that's my, so all my cousins, because Escarda is my mother's last name. So on the birth certificate, I have no father. Long story. So my dad is not on my birth certificate, so it's only my mom. So of course I use my mom's last name. So all my uncles, cousins, as far as I can remember when I said we put those people with cirrhosis in one room, they all look alike? That's what happened. Yeah. So when I saw my uncle die, another uncle die, this cousin die, all when I was a small kid, they all look alike. They all look the same. How come they all look the same? They weren't like that. I remember, when they were alive, and then when we visit, when they're already dying, how come they all look like this? I was 5, 6 years old until I was 10. And they all underwent, because they weren't making any sense anymore. Like they were just talking, nonsense like that. And then I remember my cousin, what's his name? Willie. Yeah, so that was William. Yeah, Willie, because we call him Willie. So William. When I touched him, like that. Then I remember taking him to the hospital in the van, and his brother, my other cousin Tote. I don't know what Tote's real name is. Just call him Tote.
Okay.
Yeah, and the guy was crazy. So he had a window open, right? Because of course it's a private car, and it was a van actually. It was in the front, and then he took off his shirt and was doing this.
Oh,
He said, "What are you doing?" My brother said, driving. He said, "What are you doing?" He says, "Oh, this is like a siren. We're gonna be pulled over." because of you." Anyway, so my cousin Willie was dying. So he was in hepatic encephalopathy already. So he was all yellow, no big belly. Okay, so management here. So the patient again has poisoning, basically. This is blood poisoning. Okay, so ammonia levels are sky high. There are many stages. Okay, I think the book, yeah, here. So when you reach stage 2 or stage 3 and up, because this ends in stage 4, this is what we call asterixis. So this is evidence of, we call it a liver flap, asterixis, like this. So this is now evidence that your nerves are really irritated. So when you ask the patient to suspend their arms like this, they will have flapping tremors. They can't hold it still. They will have this, right? They will do this repeatedly.
The nerves are really working.
Don't
Is
say
there
anything
evidence
about
that
the
the nerves
nerves.
are really?
The nerves.
are
Yeah,
really
irritated.
Oh, because of the buildup.
Ammonia. So asterixis, Again, I repeat, stage 2 and up. They also have this stinky breath, smells like crap.
Because the phone.
Yeah. And here are a few things you ask them to draw. So they'll draw a star like that. Okay, and then they'll write like that. All evidence of, again, the nerves are already irritated. Management. The only treatment here is lactulose.
Right.
So the liver is no longer getting rid of ammonia, so it needs help. We have to give lactulose. Now, typically, this will be given 3 times a day, but we have to control also not giving too much because this is a laxative. So you only give as much lactulose to produce 2 to 3 soft stools a day. 2 to 3 soft stools per day. So please take the initiative, okay? So I had a patient recently. This guy has been having 8, 10 liquid stools per day. And the nurses kept giving lactulose 3 times a day, right? So I advocated, it's never given at night. So the day shift takes care of it. I mean, why would you continue giving it? The poor guy is, crapping nonstop and we have him on IV fluids and of course it's your initiative, okay? So stop giving it if the patient, what's the goal again? 2 to 3, and did it say diarrhea? No, it says soft stools, okay? So if the patient makes 2 to 3 soft stools per day, is it working? Yes, and the ammonia is dropping if that's happening. Are we clear? Because what's happening if they have diarrhea? Now you have fluid, yeah, you have fluid and electrolyte problems now. Right? So you might be causing discomfort now. And as long as the patient's alert and oriented, is the ammonia really high? No more, right? Patient's making sense, okay? They're talking to you, they're independent. There's no need for the 3, right? So once maybe, just to maintain, right? But if they stop, of course, stop making stools, you have to give it. Okay, so you give as many to produce what? What's the goal? 2 to 3 soft stools, okay? Not diarrhea. So here's a warning, just a reminder. Okay, so don't go out there, practicing, and then giving this nonstop just because it's ordered. So here are some unfortunate side effects: bloating, cramps. So it says sweet, but I've never seen a patient say it's sweet. So patients who are already comatose, you can give it through a feeding tube. Now, another options are non-absorbable antibiotics. So these are, when we say non-absorbable antibiotics, meaning, you take it by mouth. Okay, so this is not IV, obviously. So here, this will reduce levels of ammonia-forming bacteria in the colon. So these 3, okay? Between the 3, we use metronidazole. And these are your monitoring. Again, okay, once the patient is already in encephalopathy, we now restrict protein. Are we clear? Otherwise, yeah. Otherwise, because remember, the liver is diseased, correct? They need rest and you need protein to, for muscle and tissue build, yeah, to heal, right? We do that. Post-op patients are always encouraged protein, yeah? So sick patients, yeah, we give protein. However, this is one exception because the more, especially with after TIPS, remember. So after TIPS, there's no more blood going through the liver, right? So no more ammonia cleaning. So now we restrict, right? So the protein, the restriction depends on what? The ammonia level. So if the ammonia is high, we restrict protein. Ammonia is okay? Yeah, because remember, it's a delicate balance. You need protein to heal that liver, but you also don't want too much protein to cause encephalopathy, right? So here, the danger of protein malnutrition far outweighs the risk of worsening hepatic encephalopathy. Are we clear?
Mhm.
Right, so it's a delicate balance once we get to this point though, right? Otherwise, we don't have to think about protein restriction. Only when the ammonia levels are dangerously high, especially after TIPS.
Mhm.
And I think the encephalopathy is last. Let me see. Yeah, this should be it. Yeah, we already talked about bleeding. That's and we finish viral hepatitis already.